A 28-year-old male patient who presented with one episode of seizure and headache for 1 month. He came to our ER and he was evaluated with an MRI brain, plain and contrast, which revealed a massive tumor in the right side of frontal region extending from the gene of the corpus callosum. In the MRI, we can see the tumor is very large and is arising from the corpus callosum, and it is also pushing the ACS to the left side. There is surrounding edema that is extending into the frontal lobe and is causing mass effect and slight midline shift. With these findings, he was planned for a craniotomy, frontal craniotomy with interhemispheric approach and excision of the tumor. Frontal craniotomy was planned, which is extending to the opposite side, superior sagittal sinus. It extended to the opposite side of superior sagittal sinus, exposing completely the anterior part of superior sagittal sinus. Here we can see the superior sagittal sinus and we are slowly opening the dura, exposing the frontal lobe up to the interhemispheric area. Now we are carefully dissecting out the bridging veins that are going into the superior sagittal sinus without damaging any tributaries. We can also see the arachnoid granulations which are on the under surface of the dura. Now we are carefully separating with sharp dissection the super, the bridging veins. We can see the arachnoid layer that is being attached to the superior sagittal sinus and the sinus, and we can also see the cortical veins. A traction suture was taken, and later the arachnoid is slowly peeled off from its attachment, and we can enter the interhemispheric area through this window. Only a small windows are possible whenever there are multiple draining veins into the superior sagittal sinus. Here, luckily, only the adhesions were seen. There is no large veins that are draining into the superior sagittal sinus. Now we can carefully dissect out the gap between the interhemispheric area and we can enter the interhemispheric area. Here we can see one draining vein into the superior sagittal sinus, which is carefully left intact, and any adhesions surrounding the vein are separated. A cotton pledget is always used on the brain surface to minimize any traction injuries. Here now, after retracting, after with the dynamic retraction, we can see the surface of the glioma over the interhemispheric area, and we carefully open into the tumor. After entering the tumor, then we start dissecting out the tumor bit by bit and aspirating it with the suction, and we enter the core of the tumor where we can see some necrotic area in the tumor. We slowly use cotton pledges to achieve hemostasis and slowly start debulking the tumor. Once the tumor is identified, our dissection and surgery mainly concentrates on debulking of the tumor, and we use bipolar and tumor holding forceps for removal of the tumor. The bleeding has to be controlled at every step, achieving good hemostasis so that our field always remains clear. The tumor is slowly picked up bit by bit, and we can see the normal brain area which is edematous, that is densely adherent to the tumor tissue. Here we cannot find any capsule, though clear capsule is seen. We slowly coagulate the tumor and remove the tumor bit by bit. Meanwhile, we also have to use cotton pledgets to prevent any damage to the normal brain. Here we can see one cortical vein that is lying just over the tumor, which is carefully retracted without damaging it. Now, after retraction of the normal brain, we are concentrating more on the lateral aspect of the tumor, where we are trying to find out a space between the tumor and the normal brain. With every step, we use cotton planchets that are carefully placed between the plane that is achieved between the tumor and the normal brain. Once the plane is achieved, we can slowly dissect out the lateral margins and we can enter the tumor. Here, the tumor is very large, extending into the lateral aspect. So, the plane creation was difficult. So, again, we are going for debulking of the tumor. Again, some part of the tumor is being debulked and it is being coagulated and aspirated with suction. Once adequate debulking has been achieved, we can again go for the separation of creation of the plane between the tumor and the normal brain tissue. In all these steps, the cortical vein that we have identified earlier has to be preserved. Now we are using a debrider. As the tumor is very difficult for suction, we are using a debrider to slowly debulk the tumor. So the debrider is being kept and the debulking is being done, and any blood that is coming, any amount of blood that is coming has to be aspirated and has to be stopped. Hemostasis is at most important as it creates difficulties in creating the plane. Again, we are using the debrider here and slowly debulking the tumor bit by bit. We are debulking the tumor, the central part of the tumor here, and once that is achieved, now we have moved to the upper pole of the tumor, anterior aspect, and we are trying to create a plane between the normal brain and the tumor tissue. In all these steps, we can see the cortical vein that is being held intact without any damage, and this has to be done slowly. And we use the tumor holding forceps to slowly debulk it now. And later, we also use debrider to remove the tumor, debulk the tumor. Now we are using the debrider to slowly debulk the anterior pole of the tumor. You can see a good amount of debulking that is being carried out. Once that is done, we again see that there is no active bleeding that is coming from the tumor bed or the normal brain area, and all the veins and arteries that are there that are preserved. Now we are again moving into the lateral aspect of the tumor and use the debrider to slowly debulk the tumor again. In every step, hemostasis has to be watched carefully. Once the debulking has been done using the debrider, we again go for creation of the plane between the tumor and normal brain. Now, after the adequate debulking, we are again trying to create the plane between the tumor and the normal brain. We can see the areas of normal brain that are being visible through the tumor bed. We can see the grayish tumor area and ivory colored normal brain here. Here the haptics, the tactile feel is also very important to rely on the how much amount of tumor that is being removed, how much amount of normal brain that we encounter. We have to identify the tumor tissue on the normal brain by color, feel, and sometimes through suction, the strength of suction also. We are going into the medial aspect where we can see the ACAs, anterior cerebral arteries, that have been pushed earlier by the tumor to the opposite side have come back into the normal place. Now we slowly debulk the part of the tumor that is in the medial aspect, and we follow the tumor to the origin that is from the corpus callosum. Again, the tumor is now being debulked with the debrider, and we can see the tumor is being easily sucked into the debrider, and again we have to look for adequate hemostasis in this step also. Now we can clearly see the anterior cerebral arteries, which were earlier pushed. Now they have fallen into the normal place. Now we are removing the remaining part of the tumor, that is on the lateral aspect and the superior aspect. Um, and again we'll concentrate on its origin from the, we will follow the tumor till its origin from the corpus callosum. Now we can see the bits of normal brain from the lateral aspect that is being exposed. And we try to preserve as much normal brain as possible. As it is in the frontal lobe, we can also dissect a part of normal frontal lobe, uh, as it gives a good margin of resection. So you can see the areas of normal brain and the tumor tissue, and the junction between the normal brain and the tumor tissue is also visible. Again, we try to use the debrider to remove all the dissected out part. So you can clearly see the color difference between the normal brain or edematous brain and the tumor tissue. The tumor tissue is grayish white in color, which is vascular. We can see continuous ooze from the tumor tissue, and we slowly use the debrider to remove the part of the tumor area. In every step we use cotton planchets. After getting a good normal brain margin, we use the cotton planchets to pack the area and continue debridement with the continue debulking with the tumor. We preserve the normal brain and we continue debulking the tumor. See, now after removing the tumor bed, we can see the normal brain that is popping out from the undersurface of the tumor. The plane is being created between the tumor bed and the normal brain. You can see that the color difference from of the normal brain and the tumor. We try to achieve a good margin of resection in these cases, as it is in the frontal area. We use both dissector and the tumor holding forceps along with the debrider, depending upon the need. Now we are creating a good space from the anterior aspect, a good plane between the tumor and the normal brain. Even the edematous brain, some part of edematous brain is also being removed here. And now we can see the tumor uh, being removed from the frontal area. You can appreciate the tumor and the color difference between the tumor and the normal brain. Now a major chunk of the tumor from the anterior aspect is being removed with the tumor holding forceps. It is densely adherent to the normal brain. Even a part of normal brain is also being dissected out. We try to preserve all the normal vessels, even the cortical veins, and give a good wash, and we can now again go into the tumor cavity. Still we can see a part of tumor that is adherent to the lateral aspect and the frontal aspect. Now that part is being debrided using a debrider, and we can achieve good removal of the tumor. Only a small part of tumor is still adherent there, that is being debrided. A major chunk of the tumor has been removed, and we try to remove all the margins that are adherent to the tumor, all the margins surrounding the tumor, and some part of the tumor is which is difficult for to be removed is coagulated. After packing with Saticel, we see that there is no further bleeding, and we pack it with dry cotton, dry cotonoids, which are removed later after the surgery. Now we are moving to the medial aspect of the tumor. We adjust our microscope in a way that we are looking into the falx and the medial aspect of the tumor and the interhemispheric area. We slowly lift the cortical vein and we go under it, and we slowly debride the tumor. We can see the tumor along with the necrotic areas that are present here, which is slowly being separated from the normal brain using a bipolar, and we debride now it with a debrider, and we are debulking it with a debrider. Once a good amount of debulking is achieved and we enter the base of the tumor, we slowly start removing it with tumor holding forceps, and also achieve hemostasis at the same time using a bipolar. The ACS are slowly separated, and they are separated from the tumor tissue using a surgical sheet and cottonoid. Later, the remaining part of the tumor that is present in the medial aspect is being aspirated simultaneously with the suction and coagulated with the bipolar, and we slowly follow the tumor to the to its origin, that is in the corpus callosum. We remove any attachment that is present in the corpus callosum, and after that we proceed with the hemostasis. Now we can see the normal brain that is popping out from the now we can see the normal brain from the undersurface of tumor. That means we have cleared the origin of the tumor from the corpus callosum. Now we are giving a wash, and we finally go for final hemostasis and check with Valsalva maneuver. Later we close the dura in watertight fashion. This patient was extubated after 6 hours, and we identified no deficits in the patient. Patient was able to ambulate on the second day, and he was discharged on third day.